Hello, my name is Mark Baines with Training Made Fun, and this is the Functional Anatomy and Kinesiology section of information that every personal trainer, every athletics coach should know. If we're working with other people, they're paying us for our services, we better know this basic information, including a physical education teacher, anyone working in any environment for schools as well. That said, this is often used as preparation for certification for personal trainers, but really it can be used for anyone who's already training and working with other people or who is looking to do that in the upcoming or near future. So first and foremost, starting with the idea of kinesiology. It's basically the scientific study of human movement. We talk about moving in general, we're talking about kinesiology. What we have to understand is basic movement terminology as it relates to those movements. So we have a better idea when you're moving forward, moving to the side, moving behind, moving rotationally out to the sides. Generally speaking, what would that motion be called? What plane of movement would that really be in? So we have an understanding of where we're moving. And then, and only then, if we understand the internal and external forces, will we know what muscles are actually at play. It can be a very common thing for a lot of people to feel that just because you move a given way, that certain muscle is always working, and it's just not the case. There are too many variables at play. It's not that simple. It would be nice if it was. It isn't. So we have to have a better overall understanding of the terminology, better understanding of, as we move, what joints are moving, what planes are involved, and then and only then can we really understand, with the forces at play, what muscles are involved. It'll be the first thing that most people want to know is what muscles are involved. It's the last thing we can determine until we first know a few other points of information. Starting with basic idea here of standing in a normal position. When we're standing with our hands at our sides, basic anatomical position is, generally speaking, the home base for a medical reference. When you look in a textbook, generally speaking, you see the body being shown in anatomical position with would be if the person was standing, an upright position with palms facing open. The reality is it's really specifically referring to someone laying in a gurney, unconscious or dead, a cadaver, with their palms open in a supinated forearm position or externally rotated shoulder position. That's generally what we're talking about with someone being unconscious or no longer with us. Anatomical neutral is really home base for training. When someone's standing upright, probably not laying down specifically, but it would be the same concept, but standing upright with hands at sides, facing the sides. So that's the home base, meaning when standing, that particular posture would be the least stressful position for the body to be in. Head not particularly forward or backward, not leaning to the side, shoulders not forward, backward, up, down, rotated. Everything is about as neutral as it can be relative to itself. Okay? And we'll talk more about that as we go on. That said, in the planes of motion, there are three basic planes. When you're moving forward and backward, that's the sagittal plane. Anytime you bring your arm forward and bring it back behind you, you bring your leg up, which really we refer to as hip, or your arm forward referred to as the shoulder. We often refer to it as the hinge. We don't often refer to a door opening. Say, I'm going to go open the door hinge, but that's really what we're talking about. When we talk about movement as a whole, we don't specifically say arm, we say shoulder. You wouldn't say door, technically, if we were referring it the same way. We'd say the door hinge. I'm going to go open the door hinge. So we're always talking about the hinge, the place where two bones meet. That's basically the hinge here in this case. That's a joint. Two bones meet there, and movement can occur at that place. It isn't. Sometimes there's a little bit of movement. Sometimes there's a lot of movement. Depends upon the makeup of the joint itself. Depends upon someone's specific mobility and flexibility. How often they use that area. There's so many variables as to why someone can or can't move a particular way or to a certain level. Okay. Some of it's structure. Some of it's basic time, or in some of it's genetics. Right. The sagittal plane will always be forward-backward. If you could only move forward and backward and couldn't turn to the sides, couldn't bring your arm out to your side, that would be basically sagittal plane. Everything forward-backward motion. The plane divides you in left and right, and everything's forward and backward. If you turn to the side and lifted your arm forward, your arm would still be moving the sagittal plane, because relative to you, it is still the sagittal plane. It's not relative to space, it's relative to you. Frontal plane. Anytime you move out to your sides, you bring your arms out and away from you and back down. That's abduction and adduction of the shoulder. Every time you move away from you, that's going to be a frontal plane as you move out to the sides away from you. The frontal plane divides you in front and back. Staying on that plane would make it the frontal plane. Sometimes it can be helpful too to think of it if you can't imagine staying on the plane, like forward, backward, sagittal plane dividing you in left and right, so you move on that plane and stay on it the entire time. You could also imagine it as being two planes, or two plates, if you will, on either side of you, and it's keeping you from turning to the side. It's keeping you from moving to the sides or rotating. You can only go forward and backward. Okay, that can also work. Frontal plane, same idea. Divide you in front and back, technically, anterior and posterior. anterior being the front and posterior being the back. But you can also think of it as being a plane or a plate on both sides, on both the front and the back of you, and you could only go out to your sides and move everything that way. You kind of go laterally to the left or to the right, and that's it. That's all you can do. That's frontal plane. Horizontal plane is rotation. Anything moves across in front of you. If you lift your arm up in front of you, we have sagittal plane motion. You bring it across from that point on. Now you're moving the horizontal plane as you move out and away from you, out in a rotational manner. Anything that turns and rotates is going to be horizontal plane dominant. Or if we said what plane are you moving in, you refer to it as either sagittal, frontal, or horizontal. If it's moving between planes, which a lot of movement is, if it's not just one specific movement, we call it multiplanar. Okay? People often say that functional movement is multiplanar, but that can't negate the fact that even a sagittal plane motion or frontal plane motion or horizontal plane motion by itself is also functional. Be very careful what we call functional. The most common definition for functional is exercise that mimics everyday life. That's not untrue, but it's not real clear, not as clear as it should be, because it doesn't just mimic everyday life. You want to move better in the gym, move better when you exercise, so that when you go out in everyday life, you move better. So we refer to functional exercise as not mimicking everyday life. Actually, no. What it is moving better by understanding the body as a whole when you exercise, when you move in general, so that when you do go on with your life, you move better. So functional exercise is any movement that helps you move better. Biomechanically efficient motion, which brings an understanding of the body and the structure and the genetics of a given person and a given level of experience and expertise or movement skill, on top of any variable skill levels and capabilities, strength they have right now. Then we determine specifically what's functional for them. There's no such thing as any given exercise that by itself is functional, because it depends very much on individual characteristics of every person. That said, going and looking more toward the sagittal plane, we're moving into flexion. When you bend a segment, you have two bones. One bends and moves toward the other one. It's typically referred to as flexion in the sagittal plane, moving forward or backward, but moving one bone toward the other one, decreasing the angle between them. A straight line is 180 degrees. You decrease that line, moving into flexion. You increase it and keep increasing it, perhaps going beyond 180 degrees, going to technically what we'd be referring to as hyperextension. If you brought your arm back behind you and past your body, you wouldn't just be going into extension as you go back, yes, but you'd also be going into shoulder hyperextension once you pass your body, technically. And the picture is showing the knee here, knee flexion, when the lower leg, the tibia, moves backward. Okay, it would be if moving backward toward the hip. When it comes forward, it comes back forward again, trying to straighten the knee out. That's going into extension. Moving toward neutral is often referred to as extension in many cases too. We're moving away from neutral, flexion. That's not always true. There's always exceptions to every rule. Generally speaking, the bending of segments is flexion, and the straightening is extension. And elbow situation, arm is straight, anatomical neutral. Bend the elbow. You have elbow flexion. You straighten the elbow back towards anatomical neutral again. That's elbow extension. The person leaning forward in the third picture here, there's a lean forward, hip flexion. That's not a back motion, that's a hip motion. They're moving from the hip, the place where the femur meets the pelvis. That's what's moving. As a matter of fact, if you move forward, like bowing forward, that would be hip flexion. If you stood up real tall and just brought your leg forward, that would still be hip flexion. In both cases, same concept, different bone moving each time. Remember, we said a joint is a place where two bones meet. So either bone can move. If the upper bone in this case would be the more proximal bone, which would be the pelvis is moving, you'd look like you're bowing forward into hip flexion and coming back. If we're talking about hip flexion with the leg moving forward, the femur, that's the more distal bone, the one farther away from the midline that's doing the movement. It's still hip flexion. Likewise, same with hip extension. As the woman here comes back toward neutral after having been flexed forward from the hip, she comes back, she's coming into extension. If she kept going beyond her own hips, going back farther, she'd be going to hip hyperextension, right? As likely, or as well, as she brings her leg behind her, if she kept her spine still, moved her leg behind her, that would be hip extension as well. Hip hyperextension, technically bringing her leg behind her if she did that. Distal hyperextension, okay? Like a lot of things, these terms are not going to be easy to pick up. It's the first time. You cannot let yourself get frustrated by the fact that there's a lot of terminology here. Any new field, anytime you hear any new term, when it's new to you, it's a little frustrating, especially when you hear not one or two, but 15, 20, 30, 40, 50, 60 terms. Don't let that daunt you. Don't let that concern you. Just keep going over the information until you get it. Once you know it, once you have memorized it, then you have to try to understand it, right? Once we understand it, then we can apply it. Once we can apply it, then we're going to start evaluating and evaluating and synthesizing it, what makes sense in real life. But we can't even get to the point of application if we don't both know and understand it first. Memorization, better clarity on what that really means, then applying it, then we can talk about applying it to somebody else, right? There are exceptions to the basic rules of flexion, extension in the sagittal plane. Plantar flexion and dorsiflexion, when you actually move your ankle. So if you were to point your foot away from you, that would be ankle plantar flexion. You point your foot back towards your knee, bring your toes, point them back towards your knee, that would be ankle dorsiflexion, okay? Those are two exceptions in the sagittal plane that are not just purely flexion and extension. They're unusual ones. For the picture, the final picture there with the wrist, as the hand goes forward, that's actually going to be wrist flexion, coming back here, extension. Bending toward the, basically the hand looking like it's coming down toward the forearm. It's going to be flexion as it comes back away and toward neutral again, going into extension, coming back. A lot of people, when they're typing on keyboards, they're spending a little bit of time, unless they're typing on a laptop, in most cases, they're going to have their hands more slightly toward extension, which is why a lot of people get bothered performing extension-related activities when they're loading their hands, like push-ups, or things like putting your hands on the ground and loading your body up. It can be hard on a lot of people because they already have spent a lot of time in that position. Something to be considering when we actually load people up. It may not be the best idea for some to load them up, pushing into greater extension than they already are on a daily basis. Frontal plane. Frontal plane is more to the outside. So as it shows in this picture, also called the coronal plane, divides you once again in that front and back. Anything moves out and away from you. The anterior posterior axis actually refers to if there were an axis going through you, actually going through the middle of you, like a pole coming through the middle of your belly button going out behind you, and you would actually revolve around that axis point. That's why it refers to as the anterior posterior axis. It goes through you, through the anterior and through the posterior. You revolve around that. That's always going to be a frontal plane motion, revolving around that axis point, if you will. Think about that axis point on any particular joint. Shoulder, go through the middle of you, going through your head, going to your neck, right? Rotate around that, going through the middle of your spine, rotating from there, and so on, okay? And it's going to be abduction and adduction, referring to, like the two pictures shown here, as she brings her arm out to her side, that's going to be shoulder abduction, okay? As she returns back toward her side, bringing her hand back toward anatomical neutral, that's going to be shoulder adduction, adduction, coming toward. Abduct away, adduct toward, right? And then her hip, as she's standing there and brings her hip away from her, that's going to be hip abduction, brings it toward her, hip adduction, adduction, okay? A few exceptions, and there are a lot in the frontal plane. If you elevate your shoulders upward and you depress them down, that's still frontal plane. That's still a frontal plane action, okay? Still moving in the frontal plane, going upward and downward. Upward, downward rotation of the scapula. If you actually bring your arm out to your side into shoulder abduction, at the same time you're doing that, at a certain point, your scapula is going to go into upward rotation. As you come down in downward rotation for the scapula, you're also going to get depression at the same time. Depression will start as you come down with the shoulder pressing down. The scapula is actually going to be rotating downward while that's happening if you're also bringing that humerus up, out, away from you at the same time. A lot of bones moving at one time in many instances, especially when you're actually talking about abduction or adduction of the shoulder. The more you bring the arm up and do shoulder abduction, the more the shoulder is going to elevate and the more the scapula is going to upwardly rotate. A lot of things happening there. The clavicle, collarbone's moving upward, the scapula, the shoulder blades rotating upward, the humerus is actually coming out and away from your side, and that's frontal plane action, okay? Inversion and eversion. If you look at her foot down the bottom of this picture here, when she's going abduction, adduction, while she was doing that, or while she was standing, if she turned her feet in, so the soles of her feet faced in, that would be referred to as inversion. If she tried to put the weight on the insides of her feet, the soles of her feet faced away from her. If you ever try to do that, it's kind of awkward and does not feel very comfortable at all. Hard enough to go on the outsides of your feet facing each other in inversion. Eversion is even more difficult. And then lastly, well, second to lastly, if you rotate your forearm, not rotate forearm, excuse me, bring the thumb toward the forearm, that's radial deviation. Pinky toward forearm, that's ulnar deviation. People do that far too often when they're loading up the wrist. Keep that wrist neutral in most cases. Don't load it and radially and ulnarly deviate it if you can help it. Last point for our first section here of 4 with kinesiology is lateral flexion. Lateral flexion of the spine is when you bend to the sides. Generally speaking, we're talking about thoracic spine, lumbar spine, and cervical spine laterally flexing. Your neck, cervical. Middle back, thoracic. Lower back, lumbar. That said, we'll cover more in our next segment, part 2 of functional anatomy, kinesiology with training made fun.